Uh, I want to thank the AIO Scientific Committee for giving me an opportunity. So I'm going to talk about amniotic membrane versus tarsography and combined strategies. So we have all come across these tricky situations in our OPD practice. Graft infiltrates, persistent epithelial defects, infectious keratitis, and we're often left wondering what should we do and what should be the right approach. So it's not going to the next slide. Yeah, so a systematic approach helps and starts with taking a detailed history. Good slit-lamp examination with documentation helps, and a microbiological examination by sending corneal scrapings for grams cavity staining and culture sensitivity is very helpful in deciding the medical and surgical management. And what are the tools in our armamentarium? I'm going to talk about the first three here: tarsography, amniotic membrane, and the combined procedures. So tarsography has been reported to have 80 to 100% success rate. Yet it is quite underused as a prophylaxis and treatment option in treating the corneal surface healing problems. The benefits are it allows more oxygen to go to the cornea, it prevents anaerobic atmosphere, and also retains eye, especially in one-eyed patients. The mechanism is it reduces palpebral fissure, thus decreasing the evaporation of tear film, and promotes epithelial healing. And also the windshield wiper effect is taken care of because of the constant blinking movements of the eyelids. So the indications are persistent epithelial defect, exposure keratopathy, neurotrophic keratopathy, post-corneal procedures, severe dry eye, lid malposition, and post-chemical burns. Now the type of tarsography depends on the location and the duration. It can be temporary or permanent. It can be lateral, medial according to the position of the lesion, and it can be central. Now this is a small procedure, just describe it. So after giving a good local anesthesia, fortunately the video is not playing. Can you play the video, please? So the process basically involves creating a raw area on the intermarginal strip and passing the sutures through a bolster. Now these bolsters can be prepared by an IV set or a scalp vein. We can just pass it from the bolster to the lid margin, make sure that the suture goes through the raw areas and they are well opposed in front of each other. And the sutures are then passed in the from the opposite side, the sutures turned around and then it passes again, and the knots have to be tight so that they're not there's no slippage. Fortunately, the video didn't play. So there are some, these are some outcomes of tarsography. Here's a case of HSV keratitis who showed initial response to topical and systemic antivirals, but thereafter there was not much improvement, so a tarsography was done and it showed great improvement. Permanent tarsography can be of great help in cases where there's repeated episodes of stromal keratitis that results in scarring, and this is an old 65-year-old male who underwent the procedure and there was no recurrence for the last 1 year. But not always will a tarsography work. There are some cases where after initial healing, like in this case, this is a case of optical PK where the nasal part was not healing. So in this case, we had to do a amniotic membrane and it showed improvement with minimal scarring. So that brings me to the next part, that is the amniotic membrane. So we all know it's a biological tissue that is helpful in ocular surface reconstruction. The mechanism is basically the growth factors in the amniotic membrane which are responsible for the anti-inflammatory, antimicrobial, and antifibrotic properties. Now, there are some common indications of amniotic membrane, but apart from the ones in tarsography, it can also be used for pterygium, in OSSN, symblepharon release. We all know it's very helpful in SLED, and recently also in retinal disorders like macular holes. I'll not go into the details of preparation, but you need not worry about the preparation part. There are institutes that are providing the tissue, and you also have the freeze-dried membranes. Now here's a short video. I hope this one plays. It was uploaded separately. Can you play? Can we go to the next slide? Yeah. So again, amniotic membrane is very helpful in non-healing ulcers. This is a case of a one-eyed patient who underwent the procedure, and also the important part is that it helps in reducing the scarring. This is the case of amniotic membrane for SLET. This is a two-stage procedure done for a chemical injury patient. He had first undergone symblepharon release with amniotic membrane, and then 3 months later, a SLET was done, and there was some partial success. Now there are some techniques, there are some indications where we have to do a combined procedure, such as when there's an infectious keratitis with high risk of perforation, severe chemical burns, non-healing ulcers with stromal melt, acute SJS or 10. So in these cases, such as these, there was a large ulcer with endoexudate which did not resolve to antimicrobial therapy. Combined amniotic membrane with tarso was done, and there was scarring and healing in this case. The culture showed pseudomonas in this case. Here's another case of a HSV stromal keratitis that showed great improvement after 3 months. Sometimes we don't have the amniotic membrane at our disposal, and in these cases, the option is a Tennant's patch graft, which can be very well helpful. This is a case of a graft infiltrate, which also had thinning. So a combined procedure was done, and at least it saved the eye, and we were able to save the globe in this case. So what does literature say? There's not been a lot of study comparing amniotic membrane and tarsography, but this is one case where, one study where they found out that tarsography was slightly superior in terms of pain relief and in the healing time for the epithelial defects. But this study only included persistent epithelial defects. They did not have other cases like infectious keratitis or non-healing ulcers. So to summarize, tarsography is very cheap and cost-effective. The benefits are that it has long-term protection, and amniotic membrane, on the other hand, is costly. It needs a membrane that has to be sourced. The benefits are that it has anti-scarring properties and also provides mechanical support, especially in cases of stromal thinning or impending perforation. And combined procedure is very helpful when you have a non-healing ulcer with a high risk of stromal melt or a large infectious keratitis, which is likely to perforate. So the take-home message would be both of these procedures are valuable options in treatment of corneal diseases. The choice of procedure depends on the etiology, location of pathology, and the resources at hand. And combined techniques obviously offer enhanced benefits. Thank you. Fortunately, the video didn't play.
Thank you, Dr. Jha.
Yes.
Any questions, please? Can I make a suggestion?
Sure, sir.
Kindly reduce the number of lines per slide.
Pardon me, sir?
Number of lines.
Right, sir. Thank you. I'll keep that in mind.